Physicians need to have guts. Okay, if you have patients like this, you got to step up and do this stuff.
Greetings, Craig here, Craig Stewart. It's Inspired Conversations, boy folks. Gee whiz, this is an absolutely massive podcast for me. It's my honor to have Professor Bruce Hollis on Inspired Conversations today. It's a name that many of you will recognize in the vitamin D space. Now, on screen, it's Professor Bruce Hollis, Professor of Pediatrics, Medical University of South Carolina. Research interests encompass nutritional biochemistry, maternal and child health, and pediatric nutrition. So Dr. Hollis has published over 200 papers on vitamin D, over nearly a century's worth of research, half a century's worth of research, cited over, as you can see on the screen, 62,000 times. He's a co-author of new insights into vitamin D, and I believe, Bruce, you are a member or on the panel for advisory of Grassroots Health. Is that correct?
Yes, I am, yeah.
So guys watching, it's absolutely fair to say this guest is an authority in the vitamin D space, and having completed his fellowship in endocrinology, I am sure that this is going to be a most fascinating podcast. Welcome and thank you very much for being on Inspired Conversations. Now, a couple of things to cover here, guys. None of the subject matter that we hear constitutes medical advice. I'd like to make that clear. It's always best practice to seek out the care and advice of your trusted healthcare professional. That being said, this is provided for your educational purposes only. Friends, I hope you find the content we're going to cover educational, informative, thought-provoking, and potentially for some of you in the cluster headache space, even life-changing. And I really don't say that lightly. Now, towardly, if you find my podcasts of value or enjoy the content, please consider liking, subscribing, and sharing this important information with your friends and your family. Finally, your feedback and comments are always welcomed. Now, in order to briefly give you some context and set the framework, I guess, for the conversation that is to follow, you need to know a little bit about me and what led me to having a conversation with a man whom many consider one of the godfathers of vitamin D research. Now, allow me to, I guess, set the stage for a couple of minutes here. And that background is cluster headache. It's also known by a plethora of other names, including suicide headache. Guys, I don't say this lightly. These things are absolutely nasty. Now, I just wanted to share a 20-second glimpse of the condition in the following slide and move on to tell you what vitamin D has to do with any of this. Caution, some of the stuff in the following video is fairly graphic.
It is one of the most painful experiences that a human can endure.
It feels as though somebody is grabbing your inside of your face and pulling as far out and as far wide as they can.
Difficult to watch, often unbearable to experience.
And so there you have it. I got these things back in 2013 and it rocked my world. It just turned it literally upside down, some dark and challenging years. In 2015, I was at the end of my tether. I remember saying to my wife, Bruce, I said, I'm just not tough enough to keep dealing with these things. And you'll literally do anything to stop the pain. And look, like most blokes in my early 30s, you know, to use some French here, I couldn't have given a rat's ass about vitamin D, nor any other vitamin at that time. Vitamin D, yeah, right. How could a vitamin offer any relief when likes of tramadol, even triptans, were barely touching the sides? Now, into the vitamin D regimen. It's up on the screen now. Mr. Pete Batchelor, call sign Batch, retired Navy fighter pilot, whom came up with a list of over-the-counter supplements to treat his chronic cluster headache condition around 2010. Now, the goal, there he is, Pete, in his, I told you he's an aircraft pilot. The goal of the regimen is to quickly elevate the serum 25-OHD vitamin D into the range from baseline up to between 80 and 100 nanograms per milliliter, where over 80% of sufferers see a complete cessation of attacks and a therapeutic response. It calls for a bolus or loading dose at the beginning of the protocol between 600,000 and 800,000 international units spread over 6 to 12 days. And as we will see when we look at some of Pete's lab work, Pete has raised his 25-OHD to above 250 nanograms at times in order to elicit a pain-free response. When I started this thing back in 2015, I had a baseline level of 18 nanograms per milliliter. So if you've seen that personal podcast, you'll know 8 days and 450,000 international units later, these things are gone, right? They're gone. I hugged my wife. I dropped my knees. I cried. I got my life back. How the hell can this be? 7 years later in 2022, it's nearly 2023. Here I am. I've had countless hours reading the literature, trying to understand the how and why. A vitamin, Professor Hollis, a vitamin, although it isn't really a vitamin, is it? As we'll explore and move past that preconception, although I was programmed fairly well. On screen now is the reflection of the list that you were looking at. You can buy whatever brand you want. I'm not here to sell you anything, endorse a product, or make any money. 6 pills a day kept the cluster headaches away. Now, reflected in the table that you're looking at are the results of a poll that sufferers who've followed the regimen raised and tested their level to confirm it's in the 80 to 100 nanogram range, nanogram per milliliter range, and note at which day a favorable response has been observed. Now, by 12, we can see folks report almost complete cessation of attacks or attack severity. More recently, day 5 or day 6 on the accelerated loading schedule of 100,000 international units per day. This regimen has now been successfully followed by thousands and downloaded hundreds of thousands of times from Henry Lahore's Vitamin D Wiki. The question then becomes why? Of the folks that have completed the regimen, just under 2 out of 10 of them report that the regimen doesn't work for them. For others, they may experience a fall from cluster headache remission. This has been a topic of fascination for me. What's behind vitamin D non-response? Why is it so amazing for the majority, and what is going on in respect of vitamin D metabolism in these non-responders? And those who have raised and maintained their level in in that therapeutic range, but then fall from grace, potentially what is going on, and that's the subject of today's conversation. Now, speaking about cluster headache remission and a fall from grace, Bruce, I mentioned 7 years I've been without these things, right? And like clockwork at the beginning of this November, they come back while I'm preparing for this podcast. It's really, really funny how things work sometimes. So my very first move was to get to the lab, right? And get my bloods drawn, and shock horror, my 25 hydroxy, as you can see on screen, bang in the 98 nanogram per milliliter range. I'm like, what's going on? And so as I digested that, thinking, do I cancel the podcast with Bruce? I'm going to have a rough couple of months ahead. I found myself in uncharted territory, although I decided to follow the documented regimen and load a further 600,000 international units to see if elevating my serum even higher would result in meeting a threshold for attack cessation, just like Pete has documented. That was Monday the 14th. After the 400,000th international unit, they stopped again. Yeah, so that's the background. And now I've got some personal experience into non-response in the path I followed to get back into remission. So guys, on screen are the goals I want to knock out today. I want to discuss with Dr. Hollis the anti-inflammatory regimen. He's a smart guy. He's just looked at the slides. I would love to get his professional opinion on what he's just seen. I'd like to build some confidence among cluster headache sufferers that have thought vitamin D, it can't be, and maybe instill a little bit of confidence to give it a go. Thirdly, there are some specific questions that linger in my mind in and around vitamin D metabolism, covering, I guess, the two words on the screen there, the pharmacokinetics and pharmacodynamics, the way that vitamin D is used by the body, and then finish up this conversation with some general discussion and some philosophical thoughts on vitamin D and the current state of affairs around the world. So as we pace through the meat in the sandwich, Professor Hollis, and take our first few bites, you're going to be familiar with the graphic that you see on screen. I thought we could start out with some out-of-the-gate questions around vitamin D supplementation. I get asked all the time now. Grassroots Health suggests 40 to 60 nanograms per milliliter as being in the optimal range. In terms of a target level, what are your initial comments around maintaining a vitamin D level in the 80 to 100 nanogram per milliliter range as per this regimen I've been following? You know, is it a jump from 40 to 60? Should the patient potentially thinking about trying vitamin D be warning, or what are your comments?
So the 40 to 60 nanograms of 25D is basically based on normal physiology. Okay, so prevention of cancer, mitigating the effect of COVID, what have you. Okay, but what it's not, okay, it's not pharmacology. Okay, so what I mean by that is if people have like your cluster headaches, or they have active cancer, that's not normal physiology. That's pharmacology. Okay, so under those conditions, the need to boost vitamin D higher actually is probably therapeutic. Now, for a normal person, I don't see the need. Somebody who doesn't have any pathologies, 40 to 60 to 70 nanograms is probably a good place to be. But for people who have afflictions, autoimmune afflictions, headaches like this, active cancer like prostate cancer, then that's a different ballgame. And then you need to maintain much higher levels.
And look, we're going to explore that, but you know, the caveat being, folks sitting here in New Zealand that may be watching this will seek out some information around the guidelines that are offered. And I tell you, 80 to 100 nanograms per milliliter sure sounds like a lot when the guidelines here down under a 20 to 50 nanograms per milliliter. We'll take a look on that at that in this slide, I guess, set by the Best Practice Advocacy Centre, whom set the guidelines for practice. Half the population here, Bruce, have a 25 OHD as per the graphic on screen, of less than 20 nanograms per milliliter, yet the free market is regulated to a maximum dose of 1,000 international units before a prescription is required. And so we even have BPAC touting association with adverse effects from 40 nanograms per milliliter. I guess my question would be here, looking at this table, how can these recommendations be so out of step with the graphic that we've just seen on the previous page, and again, so out of step with, for example, that randomized controlled double-blind clinical trial, that landmark paper by Hollis and al. On the dissociation of vitamin D's calcemic and non-calcemic genomic activity, which clearly shows that gene optimization, which we're going to look at in this podcast, isn't optimized until you reach 40 nanograms per milliliter. And that 10,000 international units of vitamin D per day is safe. So how is someone supposed to kind of, I guess, bridge that?
So the government here, New Zealand, Europe, wherever you are, okay, the official bodies do not recognize that vitamin D has any function beyond skeletal effects. Okay, they don't believe it has any effect on cancer. They don't believe it has any effect on autoimmune. They don't believe that it has any effect on your cluster headaches. They call that anecdotal. Okay, it needs to be, if you wanted to do that, you need to prove it by randomized controlled trials, which we can talk about later. For in the case of vitamin D, are next to worthless. Okay, good randomized controlled trials for vitamin D simply can't be done for a variety of reasons. So better data are observational retrospective studies on large groups, like the Harvard healthcare professional study gives you, in my opinion, better data to look at these things. Randomized controlled trials were designed for drugs where you have some or you don't, not vitamin D or any other nutrient where everybody has some, and then you start from there. And so if government organizations, there was just a paper published in New England Journal, which basically said there is no requirement for vitamin D at all. And it was they were looking at skeletal issues. And I don't know how to deal with that. I mean, I get called by the news. They say, "What do you think about this?" And I think, well, I said for skeleton, they might be right. For all the other things that they're discarding, they're clearly not right. They're wrong. And so when you look at these recommendations, keep in mind that they're basically recommended for skeletal integrity, because these governing organizations, again, don't believe that vitamin D has any effect outside skeletal. And that's why you get this disparity. So either you believe that it has other effects like you're talking about, or it's of no use for anything except maintaining optimal skeletal homeostasis, which doesn't require a whole lot of vitamin D to do.
Yeah, and that's incredibly sad when the general practice medical doctors, my GP, is using that information to advise their patients. And so, like ultimately in any other industry, you kind of deem into the territory of becoming professionally negligent to turn the head the other way and ignore some of these papers that are being published. But at any rate, look, let's push on, because I would say other proponents, authors that I've had on my show, and advocates in the vitamin D space do talk about 25 OHD levels, even higher than what I've been taking in the regimen. One of my guests advocates for 30,000 international units per day and a target level of 130 to 150 nanograms per milliliter. Now, on the back of your previous comment around treating pathology, at what point, I guess, do you cross the realm of naturally optimal levels, such as those you'd observe in perhaps a nudist or a lifeguard, and into the realm of perhaps, say, biohacking?
Somebody, and I get these all the time, somebody says I have active prostate cancer. Some of them, it's active surveillance, which means that they have prostate cancer, but it's not severe enough to be operated on. Others, they've been operated on, but it's not localized. And under those conditions, I tell these people, you have pathology, and this wouldn't only go for prostate cancer, it could be breast cancer, whatever. And I would say you're out of physiology here, you're into pathology. They're giving you chemotherapeutic agents. Those are not for normal physiology. And under those conditions, or MS, then 30, 40,000 units are what you probably need to be taking. And everybody is so worried about safety, but the truth of the matter is, even at those intakes, you almost never see adverse events, especially if you limit dairy intake. And the only thing you need to worry about with levels of 25 that go 150 nanograms or 200 nanograms is that you could end up with high blood calcium. But you can easily follow that. You don't want to, if you're doing this, you don't want to go in and have a blood calcium drawn. What you want to do is you want to be followed for urinary calcium levels, because that's the first thing that's going to show. All right. And it's really easy to do. You can tell your physician, if you're on those kind of intakes, look, I want my urine monitor for calcium, because if calcium is starting to spill over in the urine, that means you could be getting into some problems for hypercalcemia. Right. It'll show there first.
Right. It's an interesting point. So part of the regimen for cluster headache includes taking various lab tests, the 25-OHD panel, parathyroid hormone, and total blood calcium. These are taken at baseline and after 4 or 6 weeks on the regimen. Now, based on the grassroots table I'm about to bring up in a second, I wanted to ask you about testing. So it sounds like it's a good time to do that, and it sounds like it sounds like it might be a darn good idea when you look at this table. So I will ask you about blood calcium and parathyroid hormone assays shortly, but if I'm looking at this chart correctly, the highest recorded level of someone taking 10,000 international units of vitamin D per day, just as the regimen I follow suggests, was 260 nanograms per milliliter. Conversely, the lowest recorded level was 40 nanograms per milliliter. So I guess this data shows the reason why you may want to test, particularly if they're following the regimen I have been following with the hope of treating cluster headache. If they'd only raised the level to 40, they'd be wanting to consider taking more vitamin D to reach what looks like a therapeutic threshold. And so without testing, that person would never know. Talk to me about testing. How important is it? And is there a certain, number of international units a person is taking per day where above which they should be testing and below which it doesn't really matter?
No, so under the way that you describe your regime for cluster headaches, so you take your loading dose and then you start taking 10,000 units a day, and you could do that for a couple of months and then go in for a blood test, because by that time you're just basically taking 10,000 units a day.
Correct.
And see where your 25D levels are.
Correct.
And if they're not high enough, then you're probably going to need to look at, do I have malabsorption issues? Fat malabsorption issues? Am I magnesium deficient, which will really inhibit the conversion of that with that enzyme.
It's almost like I read your mind with the next slide, right? So let's dig in a little bit to dose response and what's behind some of the swings at either end of the data reflected in this table here. So what are the most likely reasons, I guess, in your experience for the difference in rise in serum level from person to person? Is it BMI, genetic profile, disease, quality of supplement, malabsorption? You mentioned a range of combined factors together.
Yes, all those things. And so it's a highly variable conversion. And that's why they make, you can buy in some countries 25 hydroxy under various names that you can take directly away. which are much more advantageous to raise 25D levels to a certain level. However, I don't like that. I don't like that. I don't like that regime for reasons that I'll explain as we get into this talk, because what you're doing there is if you're taking straight 25D, you're bypassing a metabolic control effect and also eliminating vitamin D itself, which I believe is really important in cluster headaches. And I'll talk about that. It's not in your talk, but you know, I'll tell you why it's so.
So I guess, yeah, I was still kind of sticking with that idea. Then if someone is trying to raise their serum level, and they're seeing a non-linear kind of rise that they weren't expecting, i.e. their level didn't rise into the range that they were hoping for, what's the answer? To simply push forward and increase the dose of vitamin D? I guess
I mean, first I would
Yeah.
start taking a 400 milligram a day magnesium supplement to see if that would give it a boost. I know it does me. Makes quite a difference in my levels of 25D in a conversion. Some people have you know, that enzyme is different in different people, that there's control points, and it's like this data shows, it's highly variable from person to person. You can't assume. So yeah, the initial testing after a loading dose and a few months on is actually critical to see where your levels would be. That being said, is once you achieve those, whatever level it is on that given dose, that's pretty much where it's going to stay. I mean, it levels out. Okay, the body controls the amount of 25D that is in the blood. It's not a linear relationship.
Yeah. You're going to love a graphic that I've got coming up in the following slides that talk to that point, because it will be a question many have thought about in terms of that. So we all come in different shapes and sizes, different colors. We're not all the same height. Look, I'm a few sizes bigger around the waist than I'd prefer. It's too many eggs Benedicts, Bruce, in my salesman-based job. Now, folks watching this may be watching this with their children's health in mind, or aging parents. In terms of calculating dose against body weight or BMI, how much consideration should folks place on calculating optimal dose, I guess, based on BMI and body weight versus general recommendations that they may find online? Is a one-size-fits-all approach appropriate in your view for a person just wanting to elevate and maintain a healthy level for optimal health?
No, because higher BMIs clearly affect the level of 25D that you will attain. Now, we could argue about why that is, and the truth is nobody really knows why. Does the vitamin D get sequestered into the lipid, into the fat tissue? It's not available. I mean, nobody knows that. But what we do know is people who are heavier, who have greater BMIs, have to push the intake levels higher to achieve a given level of 25D in their blood.
So folks will have seen that regimen I follow contains a number of cofactors, and people always talk about cofactors. What role, I guess, do supplements such as magnesium, boron, zinc, fish oil, vitamin K, vitamin A play in supporting the metabolic conversion through the various vitamin D metabolites in the liver and the kidney and in the cells? And I guess unto that, how important is it that they accompany vitamin D supplementation? Is there any like must-haves?
Well, I can only speak to magnesium because I've reviewed papers that looked at this. This is several years ago, and there was a paper that was submitted to a high-profile journal that had a magnesium part, and it really opened my eyes. And before that, I wasn't that interested in cofactors, but when I saw that paper, magnesium, it really opened my eyes about how key it is, because you cannot test for magnesium deficiency, okay? Blood tests to run for magnesium deficiency are next to useless. You can only replete yourself with magnesium, and know you're doing it by taking about 400 milligrams a day. So if you go to a doctor and say, I want to have a blood magnesium level measured, the data, the level that come back gives you basically no information about your true magnesium status. So I take a magnesium supplement, pretty much that same one right there, every day, 400 milligrams. And it boosted the efficiency of mine, basically taking the same amount of vitamin D. It pushed my levels about 25 nanograms higher, which is substantial.
Right.
I can't speak to fish oils and zinc, and because I just haven't seen enough data, but magnesium for sure.
Yeah, I was reading a paper by, I think it was Chong and all, observing the effect of varying intakes of magnesium on the relationship between PTH and vitamin D in obese and overweight adults. And the hypothesis they drew was that poor magnesium status impairs vitamin D metabolism enough to limit the parathyroid hormone response, which we're going to dig into a little bit more, because I've got some interesting labs that we're going to take a look at. But this next slide here, I think is important to drill home for people coming into the vitamin D space, potentially watching this. They've got a lot of information to process, and it isn't as straightforward as raising a level into the optimal range and observing a noticeable benefit to one's health. In many cases, you won't, and that doesn't mean it's not important. Further, the motivation for people seeking out vitamin D supplementation may often be on the back of wanting to treat an existing pathology. So I guess we've touched on it, but how would you see the approach differing between these two groups of people?
And in relation to, you mean just to keep their health optimal?
Yeah, correct. So the person coming into it seeking out optimal health without pathology, what would be, I guess, your recommendation to them?
I would say a minimum intake of 5,000 units a day.
And then the approach towards pathology really needs to be done under the care and guidance of a physician to be able to get the appropriate labs done.
That's true. That's true if you're lucky enough to find a physician who will actually do that.
Yeah, I was in that position last week where I said, I want to have the labs drawn. We're going to talk about that, but she tried to order the 125OH assay, and I said, you can drop the one off that.
That's a commonly made mistake by physicians, because they have this slide that you have up here now. They have no idea about this slide. I mean, they just know that the 125 is the active version of the molecule, and therefore it has to be the only metabolite of importance. And of course, that's totally untrue.
I would like viewers to understand the relationship between calcium, PTH or parathyroid hormone, and vitamin D, and the classical understanding of calcium and phosphorus homeostasis. So it just allows them to understand the context of safety of the regimen. And on the next slide, I'm going to show you a chart that tracks the relationship of these three lab values over 5 years of a cluster headache sufferer that reflects increasing 25OH as a result of an onslaught of seasonal allergens, which kick him out of cluster headache remission. But I don't know if you wanted to cover off briefly this slide, Bruce. What are we looking at here in terms of the classical pathway in a couple of minutes?
So this is from a standpoint of calcium homeostasis, and where, as many still believe, this is the only function of vitamin D. This is it. And what happens is vitamin D is taken either from UV light or from the diet, and then is an inert compound essentially, and then it gets into the circulation and is transported to various tissues. But in this case, they only believe it's the liver, where most of this enzyme resides, is CYP2R1, and adds a hydroxyl group onto vitamin D in the side chain. And then vitamin D, 25D, is put out into the circulation associated with a carrier protein, the vitamin D binding protein, that basically makes the 25 hydroxy vitamin D impermeable to getting into tissue. Okay, it gets into kidney because there's an active, there's a megalin tubulin complex that pulls it into the kidney, some other tissues too. But once the 25D that's in the circulation bound to this protein, the vitamin D binding protein, relegates 25D to inertness. Okay, you have a lot of it, but it can't go anywhere. All right.
Perfect.
That's opposed to vitamin D. Okay. Vitamin D, on the other hand, poorly binds to that protein and can float in and out of any tissue at any time. Okay, that's the so-called autocrine paracrine function.
And I guess for the first couple of years moving into the vitamin D space and reading the papers, a lot of charts that you will Google show 125 being the molecule that's making it into the cell, which is incorrect, and it's not that active metabolite that has been finally hydroxylated by the kidney that is responsible for the magic that I'm talking about.
Yes, for calcium absorption and parathyroid hormone suppression and all those and skeletal homeostasis. And skeletal homeostasis. Yes.
So before I show you these labs, Pete Batchley lives up in Washington State in the middle of the bush. You should see it. It looks like a magical spot. It's got chickadees that fly and feed out of his hand. It's it looks like he's got a good retirement going on. But what you're looking at is the pollen load in March on the guy's trucks. It's unbelievable, and it's this change in environmental factors that drives a change in his 25 OHD response threshold to cluster headache. Now, he's not just a fighter pilot. He has a background in zoology and biochemistry, and so has a level of tenacity to be able to collect data. And so what you're looking at are the 5-year chart of his lab assays as an example of the classical pathway of calcium homeostasis that Professor Hollis has just talked us through. And what it shows is, as he has increased his vitamin D level to elicit a pain-free response to cluster headache, you can observe the inverse lowering of the parathyroid hormone output and a gradual inverse change in his serum calcium. It's interesting, the guy's doctor calls him in May of 2018 on a panic down the phone saying, stop, you've got to stop the vitamin D immediately. And so I guess looking at these labs, the question I would ask is, at what point or threshold in your clinical experience can a person expect to see their PTH output begin to reduce at similar 25OH levels on the screen? And the other question to follow on from that would be, what does a reduction in parathyroid hormone production, I guess, reflect? Can it be considered a marker or gauge for both the effectiveness and safety of vitamin D therapy?
Well, this goes back totally to skeletal homeostasis. So the thought is that if you were vitamin D deficient, parathyroid hormone would be elevated, and that would set you up for what they call secondary hyperparathyroidism, where the chronically high parathyroid hormone causes your bones basically to dissolve. All right. And so the feeling was, when you give higher vitamin D levels, you suppress parathyroid hormone down, and it no longer is a direct threat directly to the skeleton, because parathyroid hormone is a really potent agent for initiating skeletal resorption. And it does that It does that for a lot of reasons, but it does that to maintain serum calcium levels, because serum calcium levels have to be maintained at all costs. Because if your serum calcium levels drop too low, it's not really compatible with life.
And it's not just taking it out of the calcium that you consume in your diet; it's reabsorbing it from bone. Is that correct?
That doesn't do the oral you can't take oral calcium and affect these blood levels of calcium. Like I said, it's highly controlled. The kidney will start excreting it out to maintain these levels in the normal range. So, of course, you know, you can take a lot of calcium supplements and end up with kidney stones. But you're likely, it has to get pretty severe before you see blood levels of calcium start to rise from anything other than if there's something wrong with your kidneys.
Correct. And so I guess if you were to qualify my summary from looking at these labs, it would be to say, well, looking at this, I could deduce it's perfectly safe to use high doses of vitamin D3 to combat cluster pathology and potentially other pathologies, so long as these 3 labs are monitored and calcium maintained within its normal safe reference range. Is that?
Yeah, I would also add in there an occasional urinary calcium level, which is more sensitive than the blood calcium levels. But that's correct. If I was a physician and I looked at these levels, I would say, we've done a lot of randomized trials on pregnancy and given higher levels of vitamin D. We never saw not a single incident where we ended up with hypercalcemia, not in hundreds, thousands of patients.
Wow.
So if I was a physician and I looked at this, I would say this is a non-factor. There's nothing here to warrant any concern whatsoever.
How interesting. How interesting. So I guess I'm not just making this podcast for cluster headache sufferers. I've garnered quite a following of people that are just seeking out optimal health. So as we round off this segment of the podcast, for the person to just looking to elevate and maintain a range between 40 and 60 nanograms per milliliter, then what would be kind of that daily kind of dosage that you'd expect them to be taking?
So I'll use my wife and I as an example. So my wife takes 5,000 units a day and she maintains hers at about 60. I need more than that. Okay, I need 7,000 or 8,000 units a day to maintain my levels at 60. Last time I had dropped my intake to 5,000 and I went in there and my levels were only 40. Okay, but I'm much bigger than she is, and taking exactly the same supplements. So, like I said, if you want to titrate to know what your level is going to be, you need to go on 5,000 units a day for 3 months, and then go have your blood levels checked, and if they're appropriate, keep on doing that, because that's where your blood level is going to stay. It's not going to keep going up and up and up. It's stable.
Yeah. This is perfect, right? So it speaks to
daily dosing forever is true. Okay. People take a level and they get there and then they stop and you go right back to where you were.
Yeah, so once the desired level is achieved and the dose is not reduced, right? Just thinking logically without any knowledge of the subject, doesn't it keep on increasing? Don't you need to pull back on the throttle?
No,
so
the body does that. The body does that on its own.
Right. I mean, the analogy was, if I always want to keep 60 bottles of beer in my beer fridge and I always buy 6 every week, but only ever drink 5, at some point, I'm going to end up with more than 60 bottles of beer in the fridge. And if you're thinking about vitamin D like a tank, which you can fill and deplete, then why does it not continue to rise?
These systems like the cytochrome P450, the 2R1 enzyme there's a control point. All right, it controls how much substrate or how much product is being made given an amount of substrate. But I mean, we had done studies where we were 60 nanograms, and I wanted to raise my levels higher, and it took a lot more intake to jump at 10 nanograms. Okay. So it's, again, there's nothing linear about these reactions. They're curvilinear. That shows you control points and enzyme function.
Indeed. Talk to me about cholecalciferol, vitamin D, and the graphic we've got up on screen. I added some tables on the left just to show the different metabolites. Now, does the body actually use this base metabolite for anything before the liver converts it?
Yeah, it does. Okay, and I was going to come back to your cluster headaches because, as I said, so all these compounds, vitamin D, I'll talk in terms of half-life of these compounds in the body. So vitamin D3 has a half-life of about 1 day. All right. So which means if your blood levels, you put enough in that it's 100, 1 day later with no further input, it's going to be 50. That's not true for 25D. The half-life of 25D is weeks. Okay. And the half-life of the active form, the 125 form, is a couple of hours. And this is all dictated by how much they bind to this carrier protein. Okay. Now, that's good and bad. From a standpoint of other things in skeleton, I believe the vitamin D3 is very important. And I was looking at the cluster headache data, and there was a team of scientists at the University of Utah that published a paper back in 2014 after we published a paper in 13, and I was basically saying, look, we have to pay attention to the parent compound here. It's not this simple, especially from the autocrine and paracrine, because a parent compound can float in and out of cells because it's not attached to that protein. It's just floating. It can float through lipid membranes and get into places, and it gets into tissues and that have the machinery to activate it within that cell. Could it be an immune cell, whatever, okay, brain cell. And so it can cross the blood-brain barrier like easy.
we're gonna talk specifically about that, because that passage through those windows into the blood-brain barrier is a talking point that kind of merges the question into something more philosophical. But look, I often see critiques of vitamin D intervention studies, like some papers that have been published out of New Zealand, where the supplement is offered once per month rather than on a daily basis. Well, it like again, kind of using a logical analogy, isn't that kind of like living in a cave 29 days out of 30?
Yes.
And then spending
one
in the sun?
Dosing. It's called bolus dosing. I hate it. Okay. You shouldn't bolus dose once every month or once every 3 months. It doesn't work. And it could cause more problems than it solves. But I wanted to come back to the vitamin D3 in terms of your cluster headaches. So this group of scientists, are you familiar with what cerebral cavernous malformation syndrome is?
No.
Okay. You know, these people that have, they have these vessels in their head that are like spider webs. Okay. It's a congenital malformation, and they leak fluid. They eventually have to go in and try to remove these clusters of veins. So these guys at Utah, they published this paper, and what they were doing was they were screening for compounds. They screened like 2,000 compounds. They had this automated screening to look for compounds that would stop the endothelial leakage, that stop these vessels from leaking. Okay. They found 2 compounds. Guess what they were?
A 25-OH and...
No, vitamin D. 25D was not that effective.
Right.
Vitamin D was very effective, and some other compound, I don't know what it was. They were disappointed because they were looking for some hotshot drug, to do it. And then they did the biochemical studies and found out how vitamin D stabilizes endothelial function, stops the leaking. So as much as known about cluster headaches, and vitamin D is free to get into the brain. Okay, it can, again, you have to take it every day to maintain the blood levels because it goes away quickly. Okay? And you can't really measure it. Nobody measures it, but we've done enough science to know what the levels you would get by daily dosing every day.
Yeah.
And where 25D can't get into the brain very well because it's tied to this giant protein, and there's not enough 125 in the circulation to matter.
It's everything. All the points that you're talking to are great, and really mold the following slides quite nicely to allow us to flesh out those talking points. Now, there is a second vignette illustrated in these labs that's explained with the on-screen graphic. Now, it illustrates the results of a 3-month 25OH burn down test where the person actually stopped taking vitamin D for 3 months, and he remained cluster headache pain free. So as you can see, it resulted in a drop of serum concentration of around 40 nanograms per milliliter for a raw burn rate of around 15 nanograms per milliliter per month. So the raw burn rate, then I assume, is a combination of vitamin D 25OH being hydroxylated to its genetically active metabolite in the kidneys, hydroxylation to 24-25OH2D3 that's catabolized and sent down the dumper and dunny, and 25OH being absorbed by cells in the periphery, including cells of the immune system, and to a lesser extent, losses due to poor absorption. So would you offer some commentary around vitamin D burn rate, usage rate, and also what other,
This, so you get a half-life of about 3 weeks of 25D. So if you did the math here, you probably look it over, and that's probably about once input ceased, that's about the levels that that you're gonna fall to, and then you initiate again and you go back up. But if you looked at vitamin D, okay, I mean, how much were they were taking? How much were they taking here up until the high point of 188? Was this?
Oh, they were loading at 50,000 international units per day to achieve a pain-free response, and then as a test,
so they were taking a lot. Okay, and what happens here is you have a substantial amount of 25D. Vitamin D would be the basic compound would be much higher than the 25D, but it would disappear a lot quicker.
Because of a shorter half-life.
Huh?
Because of a shorter half-life of less than 24 hours.
And so in this case, it could be that the vitamin D levels were really huge. Okay, it could be under these conditions and those intakes, it could have been 500 or 600 nanograms per ml, the vitamin D. Okay. And so it would take longer for that to wind down, which may explain why he was headache free during that period. But like I said, I'm a proponent of including vitamin D. I mean, if you're taking these doses, vitamin D's in there, okay? It's there. You're not doing any more, and you don't know what the levels. You can measure 25D levels, but the vitamin D levels you can't. But they're substantial, okay? And they're floating in. That compound's going everywhere, okay? Including into including into endothelial tissue that and it stabilizes the endothelium.
Yeah, and so I guess the question as to what influences the burn rate of the 25 OHD store may become a moot point if we're talking about the base molecule being the molecule that's initiating what we're going to talk about, the autocrine signaling effects of vitamin D. Is that correct?
Yeah, I mean, again, but it's important not to stop your daily intake.
And so, not to stop daily intake, let me tell you a story, Bruce. Let me tell you a story. So it was maybe a couple of months into the pandemic, right? And I'm cooking out the back in the backyard. And I made a mistake, a foolish mistake, and I caught my face on fire. Like it was on fire, Bruce. I was on fire. And I jumped into the spa to put the flames out on my face. And I took an ambulance to hospital, and what you're looking at there is my 7-day recovery from burning my face. Now, I did some research at the time, and the Institute of Inflammation Aging at Birmingham University Medical School had actually published a paper looking at thermal injury and critical illness and the influence on vitamin D levels. Now, my level was actually 96 nanograms per milliliter a week before the accident, and I had my labs drawn about 2 weeks after, and they'd fallen into the mid 50s, which is very, very interesting. And if my experience is anything to go by, the process of drawing on 25OH reserves to modulate the process of trauma recovery through to treatment and discharge only would further compound vitamin D deficiency through the amount being used in the acute phase of injury, and then lying on a hospital bed devoid of a diet and conditions to make vitamin D, through to the discharge advice I was given that included a lifetime of sun avoidance and sunscreen usage. And so it's almost perplexing to think that it seems an oxymoron almost to think what an interesting experience.
Yeah, no, I mean, in trauma, vitamin D levels fall, 25 levels fall rapidly. I mean, there's all sorts of reasons, people think about why that is happening, but, you have fluid loss, you have tissue injury, but it definitely is a real phenomenon.
So there's some real similarities in this paper that was just published. It was a case report. There were 6 case reports, Dr. Renu Martani, on the daily oral vitamin D without concomitant therapy and the management of psoriasis. The authors found vitamin D3 and resistance subsequent deficiency play an important role in the pathogenesis of psoriasis, that high daily dose of vitamin D3 is a safe and therapeutic option in managing psoriasis. And finally, vitamin D3 therapy offers complete remission of psoriasis without any adverse events. What's interesting to me is that the authors used an approach including, get this, the cluster headache sufferers will be amazed to say, an initial loading dose in some cases of 600,000 international units of vitamin D, followed by a calculated daily dose of between 20 and 60,000 international units, and adjusted based on parathyroid hormone response in order to avoid hypercalcemia. So I'm just going to include 3 case reports, the before and after photos. What you're looking at is prior to treatment and 3 months after. This is a cluster headache sufferer can't see inside the squash, unfortunately, but with a similar protocol being applied for psoriasis, these results, Dr. Hollis, nothing short. I mean, it's outrageous, right? And you can see in case 3, the lady has just got, you can see it on her face. Damn right, you'd be smiling as well.
Yeah, I'll just is that I did this to my sister 10 years ago. She suffered with ectopic eczema, psoriasis. She couldn't wear shorts. She had scars on her legs. I said, do this. And she hadn't had a problem in the last 10 years.
Why
the drug companies hate this. Okay. They hate it.
Yeah, and so the question I was just about to say is why is this just being published now, and why isn't it a common standard approach to treating this pathology? And then it's like cluster headache, psoriasis, multiple sclerosis. What may this indicate for the treatment of other pathologies? One has to begin to wonder.
Well, you know, look where this is published. They got it published in a journal. But if you send something like this to New England Journal or Lancet or JAMA, they send it right back to you without a review. They don't want to know this information. They would say it's anecdotal, it's not real. You need to do a randomized controlled trial. Now, think about this: is you want to do a randomized trial? Who's going to pay for that? There's no money to be. It's not a drug. There's no money to be made. Those trials are never going to be done. And so you will have to settle for these types of studies, which I totally believe from this in my own experience.
So observational data.
It's not blinded. It's not it's more than observational. It's intervention data, but the drug companies don't want this known. I mean, my sister, for a case, she you know, over her treatment with this, she went through every cream and every steroid treatment, and you know, and even there was a topical analog of vitamin D that they use, but was somewhat effective. Okay, but they can't use it orally because it's toxic. But you never saw treatments results like this. Okay, and it's never going to be. In fact, I sent this, or I saw this before here, and I sent it this week to my physician. Okay, and I said, you know, some physicians need to have guts. Okay, if you have patients like this, you got to step up and do this stuff.
And I mean, we've qualified in the previous slides that it's perfectly safe so long as those labs are monitored. They're not going to turn to stone. No,
I think it's, look, the physicians by and large take their orders from government organizations, AMA or whatever you have down there. And they would look at this and they say, this is toxic. They're going to get kidney stones, or they're going to have kidney failure, and the usual stuff that you hear. But they're not, and there's no money to be made here by anybody. You know,
I say that it's folks will be interested to know. I think if you shave a lamb of its fleece, extract the lanolin, take it through the process, it's about 1 million doses of vitamin D per lamb, to give you an idea of how cheap it is to produce. And so yeah, sure. So look, let's move on to talk about the mechanism by which it's understood vitamin D may be helping with cluster and migraine headache. Genetic expression as a result of autocrine signaling. It sounds complex, and I want to break it down for people now. Whilst it's not clearly understood the end stage pathophysiology that leads to neurogenic inflammation and pain nociception in both of these pathologies is fairly well linked to the expression of pro-inflammatory neuropeptides in the trigeminal vascular complex. If anything, migraine being a little bit more complex. It's this unregulated and excessive expression of these pro-inflammatory mediators that results in a neurogenic inflammatory response that sufferers will be familiar with: the throbbing of the head, the stabbing pain behind the eye and the temple. So there are a number of neuropeptides we know about. PACAP, it's got some crazy names, pituitary adenylate cyclase activating polypeptide. vasoactive intestinal peptide, substance P, and Big Pharma's #1 focus, of course, for the treatment of cluster and migraine headache with these new monoclonal antibodies, CGRP, or calcitonin gene-related peptide, amongst the most notable being implicated in these pathologies. There are more not mentioned and probably more yet to be defined. The slide you're looking at on screen, guys, is the binding of CGRP into its receptor site. So I'd like to set the stage here for questions regarding the autocrine signaling effects of vitamin D with some brief illustrations and statements that may, I guess, allow the viewers a capacity to follow along. Now, as humans, we're an organized collection of some 37 trillion odd cells. Here's, I believe, some fat cells. Believe they call them adipocytes, if I'm not mistaken. And all these marvelous cells do on a simplistic scale between division and death, like the animation you see now with cell division, is to produce proteins from mRNA, which are nothing more than single-stranded copies of one of our 22,000 odd genes. They're protein recipes, if you will, which are stored in the very heart of the cell and its nucleus in the book of life in human DNA. Now, in DNA, these genes or recipes, they're comprised of various varying combinations of 20 amino acids written in base pairs, consisting of different combinations of 4 naturally occurring chemical nucleotides: adenine, guanine, cytosine, and tyrosine. If you cast your mind back to middle school, it's much the same as computer code written in binary series of 1s and 0s, where 7 bits make a byte, represent a character. So too do the combinations of these nucleotides in sequence comprise the language and biology of life. And for a cluster headache sufferer, it's thought that vitamin D at sufficient physiological blood plasma levels influences, through genetic expression, the production in ribosomes, the guy that you see on the screen now, of these neuroinflammatory peptides I just spoke about, proteins that, once they're expressed, result in the very unpleasant experience of a cluster headache. So on the back of what I've just outlined, we arrive at this very cool graphic where I'm going to ask you to introduce my viewers and correct my previous statements if I'm wrong as to the autocrine signaling effects of vitamin D.
So, yeah, this was published in 2013, and this was before we knew about the effects of vitamin D per se, by the work of the Utah group. And so, if you look at you look at vitamin D there in the upper part, you get it from diet or UV, and you make a lot of it, okay, in your skin. And the half-life, meaning how long, once it appears in the blood, how long it takes for it to disappear. So vitamin D is pretty quick. It half disappears in 24 hours. And as I said earlier, this disappearance, or the appearance, is totally dictated by how tight it binds to this carrier protein. Okay, vitamin D poorly binds to the carrier protein. 25D strongly binds to that carrier protein. And if you look at the arrows, and then 125 even more poorly to the carrier protein, and its half-life's only a couple of hours. So it comes and goes really quickly. So 125, from a standpoint, we talked about calcium homeostasis. That'd be the graph there on the left, involving, yes, the kidney, where and you have vitamin D going to the liver, being converted to 25D, and then it goes back into the kidney, but it's transferred into the kidney by an active. What happens is the kidney has a megalin-mediated transport system that sits on the surface, and it can grab that whole complex of 25D and the vitamin D binding protein, pull it in, and then it's metabolized and activated to the 1-hydroxy form, which is then excreted circulates, goes to the intestinal tissue to initiate calcium absorption, shuts down parathyroid hormone. That stabilizes bone health. That's the endocrine function of vitamin D. That's, if you go into a physician's office, that's the only function of vitamin D that they are going to recognize. All right. They're not going to recognize anything to the right, where for you, and this is not to, this is most of our work was in pediatrics, and what we were looking at is, how do we get more vitamin D into the milk of lactating women? Okay, if you give lactating women high doses of vitamin D and their 25 levels are elevated, none of that passes into their milk because it's tied to that protein. It can't get in. However, vitamin D itself, because it's not tied, flows right through the blood milk barrier, and tons of it comes into the milk, and then an infant feeds and gets plenty of vitamin D. And that this has actually changed the pediatric practice, where women now can take 6,000 units a day of vitamin D and have plenty of vitamin D in their milk. They don't have to give the infant directly vitamin D like has been done forever. I mean, you can still do that, but it's not necessary. The woman can do it herself by taking enough vitamin D. But that same mechanism of vitamin D going into milk also sends it into these other tissues all over the body: breast, colon, skin, brain, ovary, prostate, whatever, okay, everything. And so once it floats in, because it's not bound to this protein, so once it floats through the lipid layer of the cell, it gets in there, and almost all these cells have the machinery, as you'll see here, to take that vitamin, activate it to 25D, and then right next door is another enzyme that'll activate it further to 125. And then within the cell, it never comes out. Within the cell, it'll do the gene expression that you talked about earlier, however many genes it regulates, which is a lot. Okay. And then I had up at the top, we were talking about endothelial non-genomic stabilization, where 25D is not really all that active to do that, yet vitamin D itself is incredibly active at stabilizing endothelial tissue. So my question here is the availability of 25-hydroxy. It can get into cells, but you had mentioned that there's a quote free concentration of 25D that's not connected to that protein, but I can tell you it is tiny. It's on the range of a normal person of 5 to 6 picograms per ml. It's not enough mass to matter. Okay, where vitamin D, okay, the free concentration of vitamin D, it's in the nanogram, it's magnitude higher. Okay, very, very high levels of free to get in and out of tissues. So, yeah. So the question is, in the brain, is that I'm not familiar with this. Does the brain have this active transport system of megancutulin that can pull 25D across that barrier? I don't know.
No, it does not. And so in terms of autocrine signaling effects of vitamin D in the brain, let's talk about this and go down this path, because the human brain is protected by the blood-brain barrier, folks. It's a semi-permeable membranous barrier localized between the interface of blood and cerebral tissue, and it's composed of a term that Bruce has used: endothelial cells, astrocytes, pericytes, and things called perivascular mast cells. So its responsibility is to rigorously control exchanges between the two compartments, allowing only certain molecules or ions to diffuse, or occasionally by more specialized processes like active transport, not including a megalin-cubalin transport system, I believe. It is thus responsible defending the system against toxic insults, regulating the communication between the periphery and the central nervous system, and also importantly to provide the brain with nutrients. So here's where I'd like to talk about vitamin D's access into the squash, Bruce. In order to carry out these autocrine effects we've just spoken about, these signaling effects. Now, here we go. Here's a good graphic. Generally, it's only lipid solubles, what they call small molecules, I believe, molecules with a low molecular weight, under 400. I believe it's 400 Daltons. So this is where vitamin D and its metabolite 25OH seem to me, as a layman coming into the space, seem like Cinderella's shoe that fits almost perfectly at 384 and 400 Daltons, respectively. Who created the system is probably the first question I ask, and it bridges a more philosophical topic to say certainly very perfect and complex. Now, when considering the molecular sizes of vitamin D with a lens to understanding which of these metabolites is able to enter the brain and deliver its payload, this is where I want to ask you about vitamin D binding protein and the free hormone hypothesis. Now, we're going to go back to this chart because it's a really good chart to use to just talk about this stuff. Most folks at home are going to be familiar with, the whole process that we've just spoken about, but we've touched on the fact that all three metabolites bind with a carrier protein, and we've touched on affinity for that binding protein. So, Bruce, let's talk about vitamin D binding protein and, to a lesser extent, albumin. What are these molecules? What is their function in relation to vitamin D? What do they do? Give us the rundown. And I want to come back to the blood-brain barrier, but let's just stick with an introduction to what vitamin D binding protein's role is.
Well, most people believe the role of vitamin D binding protein, of course, is to transport a lipid-soluble compound in an aqueous environment around the body. And also, from a skeletal standpoint, is to maintain the level in times of, if you go back to the how humans normally got vitamin D from the sun, it could be you get a lot of sun exposure one day and then you might not get any for quite a while. And it was the utmost purpose that calcium homeostasis be maintained, okay? Because all these other things don't lead to instant death, but calcium homeostasis gone awry is bad for reproduction, bad for survival in a really acute fashion. So the vitamin D binding protein I think it's a protective mechanism to keep amounts of vitamin D at a relatively stable amount, which is good, except that it blocks it from getting into, like your previous slide, being attached to a protein that's 60,000 molecular weight, okay, is not going to go through that blood-brain barrier.
Indeed.
It's going to bounce off unless there's a transport system, and I don't know that there is one. On the other hand, vitamin D is totally lipid soluble. It would float right through that barrier, okay, because there's very loosely attached to the protein. And the active compound, calcitriol, there simply isn't enough in the circulation to matter. All right, it's tiny amounts, 20 picograms, 25 picograms. And then we come to your free concentration of 25 here. So if you have, say you go for blood test and your level of 25D that they measure is, say, 50 nanograms, you're going to have a free concentration of 25D of maybe around 10 picograms. Again, it's not enough mass to matter. Okay?
Right.
On the other hand, vitamin D would be nanograms flowing in and interacting with cells and getting into cells that have the machinery to turn it into what it should be turned. Now, except for the stabilization of endothelial, which vitamin D can do on its own. It's non-genomic. All the other things that you're talking about has to be activated through the activation of vitamin D, which means vitamin D has to go into a given cell and then be turned into the active form in that cell. And then 125 occurs in that cell and can regulate whatever it needs to be regulating.
Yeah.
I know this is complicated.
And so actually, what to kind of round those comments up, what you're saying is that at point, I think it's 0.3% of 25-OHD is in its free form, and that quite simply is not enough. Even as you increase your level and you increase the amount that 0.3 represents, it's more likely to be cholecalciferol that's venturing into these cells. So what percentage, I guess, of cholecalciferol binds to the I mean, obviously, when you produce it in your skin, it's got to get to the liver. So it does get bound, but not all of it.
It's not all. When you put vitamin D into the circulation, it binds to like lipoproteins. It binds to all sorts of things.
Right.
Where 25D goes right onto that protein. All right. And keep in mind that if 25D does pass over into the brain, it still has to get into the cell and be activated to 125. Okay. It can't act as it is. It has to go in there and get activated. And my point is, there really isn't enough mass of that to get into all these cells and have an effect.
Mm-hmm. Okay, so and so the 25-OH bound with a carrier protein ain't just passing through the cell wall. Okay, so it is again the free hormone hypothesis that says that the unbound fraction of that metabolite or of that molecule is able to pass through, be taken up by the cell, where the cell expresses the enzymes required to hydroxylate into its active form 125-OH2D to initiate the process of genetic expression. Have I?
And it doesn't matter if it's vitamin D or 25, it gets in there because the machinery is in there to activate them both.
So let's talk about that landing point of arriving in the cell, because this is incredibly interesting stuff. There are a couple of terms that people will be familiar with: the VDR, the RXR, the heterodimer, and it all leads to this. We've already touched on it in various facets. Draw home any points that you would like to cover here, Dr. Hollis, in reference to landing at that point where we are initiating and influencing genetic expression.
Well, once it's within the cell and it gets activated to the 125 dihydroxy form, then there's an intracellular receptor that grabs onto it, and then that receptor changes conformation and then goes in to the DNA. There's hormone response elements, HRE. You have them here, and their cells. They're everywhere in your DNA. And there's it's really complicated. And there's cofactors that initiate or inhibit the response. And then once they bind on here, then they initiate the either activation or repression of a given protein to be made, of which there are a couple of thousand.
Yeah, right. And so this dimerization occurs, and these genes are then turned on or off and regulated in terms of how many are produced, transcribed for production in ribosomes. So, it may be outside the scope of this conversation to say DNA is very complex. But what is it about those 2,500 genes that make them responsive to vitamin D's active heterodimer? Do we understand that?
No, I mean, that's actively studied, but it's again, it's very little is known. Yeah, I mean, you can pick out different proteins, you know, on the DNA, and you can search back and see if they have a VDR, a response element in them. You can find that, and that's how they can tell when you see these when you can see these of how many genes are activated, inactivated. But you know what it's actually doing and how much repression or stimulation is happening, it's, you know, like I would say, only God knows. It's really complicated. They have, drug companies have whole divisions that do nothing but try to figure this out, not only for vitamin D, but, you know, a lot of other drugs.
Yeah, correct. So not looking at the VDR in isolation, it's not the only guy looking to form a heterodimer with the RXR, is it? In the sense, how doesn't higher amounts of vitamin D disrupt binding for the other binding partners? Is there?
I don't mean it's not disruptive. It could be disruptive, or it can be advantageous. It depends on, you know, again, it depends on what that particular response element to the vitamin D receptor and what other cofactors it requires and what's controlling those. You know, these things are all, they're under control too of production. So I am not a molecular biologist by training. And one of the things about it is it is so horrendously complex to study. You can't study these. That's why I, you know, early on I decided I'm not going down this road in the molecular biology, because they were studying these things in isolation, one gene at a time. I mean, what good does, you know, they're more advanced now, you know, they can study gene interactions. But if you look at, we've published some of these things in some of our, and it's not me, it's the molecular guys. They look like hairballs. You can't decipher them, you know, literally it looks like a ball of yarn with all these interactions. So it's impossible to unwind. You can tell what processes are being affected, like immune function, receptor control. You can generally tell by the clusters that they're being activated, but how they're specifically interacting and what they're doing that's beyond the science we have today, huh?
It's a work in progress. Although
Yes.
To offer the viewers some context, if they got lost in that conversation, to say it's roughly 10% of our genes that respond to the presence of the active form of vitamin D that we've been speaking about. And to give you some context, again, there's in the human genome, I think there's about 23,000 genes. So it makes it around 2,500 that are responsive to active molecule of sunlight. I guess to frame it another way, and I'm a philosophical kind of guy, it's, you know, it's a little wonder around a century ago, Bruce, in New Zealand, we had solariums. Where if you got crook, that, you know, you went to a solarium and they put you outside in the sun. And for centuries before and into antiquity, we've worshipped this great ball of fire in the sky. And so, how interesting that we come full circle now to understand the biology in and around, and as you say, the complexity of this process by which the body grabs hold of that molecule it's made in the skin and takes it through, you know, various metabolic processes to arrive at a point where it's influencing DNA. And so it's really, really interesting.
You know, in the case of your cluster headaches, I'm relatively certain that they'll never figure out exactly what's going on. Okay. With vitamin D per se. Okay, you know, you said they're making monoclonal antibodies against some, you know, transport protein and hoping that works. But in the case of how vitamin D and what it's doing in your brain to normalize what's not normal, I don't know. I mean, you could probably, you could probably go in and do these, they call them GWAS, and look at all these genes that are up and down regulated, but you're never going to figure out.
Correct.
Okay.
And of course, and of course, those genes are going to be different depending on which part of the brain you're looking at. I mean, people, don't understand that your toe, the DNA in your toe cells contain the same information that your hypothalamus has. It's just those cells can't utilize the whole genome because you don't want your hypothalamus growing toenail and I guess vice versa. But to speak to that question, to say we're never going to really know. This paper was, I felt, a really good paper. It'll be one you're familiar with Professor Michael Hollis.
Yeah.
Yeah, and talking to the point of what we've just spoken to, can you speak to them in the context of the excerpt table from this paper that we're looking at in terms of responsiveness of vitamin D being related to the physiological concentration of how much is in the body? Well,
so 600 IUs per day is what any physician, if you go in and say, I want to take vitamin D, or government organizations, they're going to say, well, that's what you need. Okay. Then the next one is 4,000. And they're going to say, well, that amount, you could become toxic. And at 10,000 a day, they're going to go crazy. They're going to tell you can't take that. You're going to ruin your liver, you're going to ruin your kidneys. But the truth of the matter is, you look at these genes, upregulated, downregulated. Like I said, you can, and we've done this looking at these clusters, and you can determine which gene clusters for a given process are affected by this. But down here at 10,000 units a day, where your blood levels would be probably, 60 to 80 nanograms per ml, which are certainly, that's normal human physiology for sun-enriched environments. Not how we live today, but look at the number of upregulated and downregulated genes compared, it's 10 times what they are at a 600 IU increase. So to me, that indicates, the top one would indicate, the body's functioning in a deficient fashion. These genes aren't being utilized, whatever they're doing. Okay. Whether they're protecting you against autoimmune attack, or they're protecting you against actual immune function, preventing you from getting having hyperimmune attacks during COVID, whatever they would be. Okay.
Yeah. Okay. So on the back of that, right? Let's have a look at this chart that I put together, because it's a good point. Talk to me about the fluctuation of levels versus maintaining a consistent level throughout the year. I know a cluster headache sufferer is going to want to maintain that level to remain pain-free, but as we migrated away from the equator, those surely the body evolved to allow for the peaks and troughs that accompany the seasonality of life closer to the poles. And surely, isn't it the case that the amount of bugs, virus, pollen, fungi, allergens, for want of a better word, floating around in the winter air versus the summer air really doesn't change so much? It's more how robust our immune systems are, and the change between those seasons as to how we deal with those microbes. Would that be a fair comment?
Yes. Yeah. I mean, this was not ever happened when humans evolved around the equator. This was a factor of humans going north, and then trying to deal with it by lack of, losing pigmentation. And that wasn't enough. But this is not a natural phenomenon. This is a phenomenon of human mobility and sun exposure. So if you do your 4,000 or 5,000 or 10,000, you don't have this seasonal fluctuation anymore. It's flat the whole year round. You don't, I've heard people say, well, I could take it into the summer. You shouldn't do that, because you don't get enough sun exposure the way that we live, even in sunny places, unless you're a fishing guide or some other outdoor activity where you're outside all the time. But not to take vitamin D supplements in the summertime because you think you're getting enough from sun exposure, that's not happening.
Yeah.
That's not going to be true.
And to put it another way, pandemics and epidemics, those things have affected human civilization for as long as we could write on the walls of caves. Yet there were always survivors, and the question, of course, then becomes, well, who survived? And the answer is most probably those that stayed up the top with an unwavering, unchanged optimal vitamin D level throughout the seasons. Again, I mean, am I crazy, or would that be a fair statement to make?
Yeah, that would be a big contributor.
Right. And that's why we're having this conversation with world expert there, folks. And we're moving into that, into that kind of philosophical chat now as we wind down to say and conclude the conversation. Philosophically speaking, Professor Hollis, in this modern age, it seems really there isn't much difference in this sophisticated looking gentleman living in this cave or living right here next to the shoreline. He just isn't well placed to make physiologically meaningful levels of the sunshine molecule, and this seems to be the sad human story.
Especially if you're a person of color living in extreme latitudes.
Indeed. I mean, down here in New Zealand, we have such a multicultural society now. A lot of Indian people venture down here for work and to explore the Great Down Under. And it's like, hey, did you consider your vitamin D requirements moving down here? And it's just not something that is front and top of mind because of the misconception. Yet in contrast, right, it's like all of the other creatures we share the earth with are exposed and they're unafraid of our sun. And unless tainted by domestication or animal husbandry, they're making appropriate, relevant biological levels of vitamin D in line with the requirements of their species. So, what happened to us, Bruce? Like, where did we go wrong, and why did we
thought we knew too much, and then the dermatologist got a hold of this, and everybody's afraid to have a basal cell or a keratoma or some skin abnormality that would result in, and so the sun was totally shut off.
Isn't it crazy? I mean, it's like we act as though we live in isolation from all these creatures, yet we don't, and it's just phenomenal. I mean, we're coming into Christmas break here, Bruce, and you can rest assured that before anyone goes to the beach over here, it's like slip, slop, and slap, and it's when you look at it from this context, it's incredibly sad indictment on our species as to where we're at this point. And I get it, it's like not everyone is going to be one of these guys in life. And hey, I touch wood, I haven't ventured down this particular path to adopt a naturalist kind of lifestyle like this guy. But in lieu of our conversation, you could see why it could be a very considered and good choice to make for oneself. Now, even in this slide here, Bruce, I'd started to read in my preparations to catch up with you about microbes involved in the reproductive process in the womb. And it's like, there again, they play a significant role in helping baby form immunity even before they venture out into the world. So, I wanted to give you some scope here to talk about your field of research in reproductive medicine in and around vitamin D, and just share your general commentary and advice to people that may be considering vitamin D in relation to fertility and getting pregnant and birth outcomes.
So our research basically tells us that you need to start taking vitamin D before you actually want to get pregnant. Okay. A lot of stuff that we can't study because of limits on studying in the first trimester. Women don't even know they're pregnant in the first trimester. So you can't really start supplementing them until they show up and they're pretty much through that first trimester, whether it's placental implantation, vasculature of the placenta. Vitamin D is the only compound I know that we feel prevents preterm birth. And we published some of that data along with GrassRootsHealth. Now, there was one other treatment that was recently, that was approved 10 years ago. I think it's 3-hydroxyprogesterone. It's expensive. It's given as a shot. It was given provisional approval, rushed through, and now the FDA wants to remove it because it doesn't work. And so there is no treatment to prevent preterm birth. And vitamin D prevents complications of birth, gestational diabetes. It's highly effective. In our studies, we gave 4,000 units a day during pregnancy. But
yeah,
again,
it's talking about pregnancy and birth and cluster headache, for example. I can't tell you the amount of times over the years you'll see women come online that have just had a baby and they fall into cluster headache cycle, and it becomes so interesting to me to understand and maybe piece together why that may be, and whether their 25-OH is dropped that much that they fall below a threshold where the attacks start again. And so what about in terms of milk and newborns? So babies should be supplementing, or if mum's supplementing?
What was happened forever, if you're giving formula, there's plenty of vitamin D in formulas that you would get commercially. That's not true of mother's milk. Mother's milk is largely devoid of vitamin D because the mothers are devoid of vitamin D. And so we published, did a big $2 million randomized trial on this, and found out that if women in our study, we gave them 6,000 units of vitamin D per day while they're lactating, they passed plenty of vitamin D into their milk, that their infant got plenty of vitamin D without having to be directly supplemented. Now, it's changed it's changed to some degree clinical practice, because some pediatricians will tell mothers, you have this choice. You can either take it yourself or you can give it directly to the infant. A lot of mothers want to do it the most natural way, so they don't like giving stuff to their infants, so they'll take it themselves. But it actually has been quite effective. So that was something that we did that actually did change clinical practice. Now, if it's done in New Zealand, if the OBs or the pediatricians are afraid that 6,000 units is going to turn their patients into a stone, then they're probably not going to recommend it. But I can tell you that it's totally safe.
Yeah,
and it's very effective.
I didn't mean to paint such a dark picture of physicians down in New Zealand, because I tell you what, there was actually a survey done recently of 1,200 physicians across New Zealand, family practice doctors. 87% of those doctors were concerned that their patients weren't getting enough vitamin D, and so I believe that attitudes are changing. We just need legislative change and guideline change, so that they feel confident.
It's not only, I'm not singling out New Zealand physicians, we got plenty of it here.
Fascinating. I did read your paper with Dr. Bragley regarding birth outcomes and looking at what happens with the level of 125 during and after pregnancy, and it kind of made me think about animals that give birth to larger litters than we do with one or maximum 2 or 3 babies at a time. Like for example, a rodent has a litter of, or a cat has a litter of like 10-12 babies. They must draw a lot of calcium to support all those all that offspring, and how does the body recover that?
Yeah, the rise in that's what people thought initially with vitamin D, and why the 125 dihydroxy levels went up so high. It was to support calcium metabolism. But that's really not the main issue here, because as soon as the placenta is implanted, those rises happen and there's no calcium mobilization going on. Okay, it is probably due to a placental implantation, tolerance, a bunch of other lung development. It's the two questions that I ask my colleagues constantly is that during pregnancy, if you or I had the levels of 125 that you see in pregnancy, you'd be dead. You'd be hypercalcemic and you'd be in the hospital with heart failure. Yet a pregnant woman doesn't. There's no explanation why that is. And the other question is, how does the body make that much? It's tightly regulated, and it is being made by the maternal kidney, but something turns off the regulation and allows that to happen. And those questions have never been answered.
Right.
And they're important questions because they don't fit into normal human physiology. It would result in death of a normal human.
Totally interesting. Totally interesting. Dr. Hollis, it's your Saturday night. I know your wife's probably organised some dinner, but to the person that's watching, thank you. Appropriations on screen. I need to run through these. So, I mean, to yourself, Dr. Hollis, for your contributions, firstly in this field, and for taking the time to join me on Inspire Conversations. Bless you and thank you very much, sir. I'd like to acknowledge Jen from GrassRootsHealth for the support in putting this together. And it wasn't I always planned to contact you, but it wasn't me that kicked things off. It was a fellow New Zealander that's been following my podcasts and following the literature and thought, yep, he needs to talk to Dr. Hollis. And so I extend my thanks to you, Cheryl, for doing that. And my endless respect to and gratitude to Pete Batchelor for his mentorship, friendship, and support. This guy is one of a kind to have led this patient-driven approach to treating cluster headache. It really is an amazing feat that he's achieved. So thank you very much.
Thank you. And if you have any other questions, feel free to contact me.
Thanks, Bruce.
Okay.
I'll just